Welcome to our 10th podcast of ISELP In Motion, the official podcast of the International Society of Equine Locomotor Pathology. And we bring conversations with leaders in equine sports medicine industry into your truck or wherever you're listening or watching this podcast. At ISELP, our mission is to advance education, elevate standards, and definitely connect veterinarians globally. Today, we are joined by Dr. Beau Whitaker. Beau graduated from Texas A&M, completed an internship at Arizona Equine Hospital, and worked at the Four Sixes and built a highly respected sports medicine practice. He's a certified equine rehabilitation practitioner. And beyond his veterinary accomplishments, Beau is an exceptionally talented and accomplished artist, I am told, which we're going to get into, and known for his detailed and expressive work. Beau, great to have you with us.
Yeah, thanks for inviting me on. I'm honored to be here.
Well, let's just jump into it. And so why don't you tell us about your journey into equine medicine and how you got here?
Yeah, so I grew up in Tennessee on a family farm. I was the fifth generation on that farm. And so grew up around horses. My dad was a AQHA judge for 30 years and was the head of the equine department at Middle Tennessee State. So I grew up around the equine industry. Started working for a local vet clinic in high school and equine practitioner there that kind of got me into the world of veterinary medicine and fell in love with it. And so went on to Oklahoma State, got an animal science degree. And at that point, was sure I'll only work on horses. And so went on to A&M, graduated from there and went on to Arizona Equine. And so it's been for me very focused that I knew I wanted to work on horses and then specifically within sports medicine once I graduated. Once in vet school, I worked with Cliff Honest a lot at A&M, and he kind of opened my eyes to the world of sports medicine. That's where I really fell in love with it and decided that was going to be my career path from there on.
Well, Cliff's a great guy, and I tried to hire Cliff once at Arizona Equine and didn't get it done, but he went on to build a phenomenal practice in Texas and down there.
Yeah. Since then he has his own practice, but when I was there, he was luckily at the university teaching the students, so I get to benefit from that. Yeah.
And so what year were you at Arizona Equine?
It was 2005, 2006.
Okay, great.
Yeah.
And I built that practice, right?
I know. Yes.
Yeah.
Yes.
Yeah.
Your name was spoken in hallowed terms there.
Well, I'm surprised by that, but
I mean, not just that, somewhere.
It actually, when I went back by, other than building out the MRI room and the old postmortem area that I built, I was surprised it hadn't changed dramatically. It seemed somehow bigger than when I was there. I guess that's just you running around not noticing things, and then they built another entrance. But the impressive thing about Arizona Equine to me was, oh my gosh, everything that used to be alfalfa fields surrounding the clinic and that intersection is houses. I just couldn't believe how it built up.
Yeah, it's in the middle of the city now. It's crazy.
Yeah. Crazy.
Yeah.
Well, so I'm interested in this artistic thing. So you've got to tell me about that. I didn't know that.
Yeah. So, ever since I was a kid, I've been really interested in art and enjoyed it and had a propensity for it. And so I've always mostly drawn and painted. And in vet school, I don't know about you, but I was a back rower in vet school. And so,
yeah, I was probably back there too.
Yeah. And so, not that I wasn't learning, but I did lots of drawing in vet school on the back row, and I would draw cartoons and draw things and send them out around to my classmates, and kind of became known for that. And I have a friend, Don Bell, who's a really good equine artist, and I thought, I think I could probably do that. So during the third year, we had a lot of free time on our hands because we had all these electives, and I had a lot of free time, and so I thought I needed to do something more constructive than drinking beer. And so And so I was like, I'm just going to draw a big picture, real detailed, and just see what I can do to see, challenge myself. And so I did it, and I started showing it to friends, and people were like, oh, I want a copy of that. So I went to vet school in the media department and took it, and they said they could make prints. So I made prints and started selling them during vet school. And
really?
So, yeah. And, from there, it kind of just progressed. Like, people liked it, wanted more. So I just kept drawing, and now I'm sculpting. So I just bronzed my first sculpture a few months ago. And so I've gone to the 3-dimensional from the 2-dimensional now. And so I'm currently sculpting a horse and a cowboy. But yeah.
Well, I have to send you a picture of, so 2 other people that I know, now I can say 3, in the veterinary profession that are amateur artists, but good from my viewpoint. Now, I have to see your work before I can include you in that, Beau. But,
well, I've been on the cover of JADMA a few years ago, too. So.
Oh, really? Oh,
yeah.
Cool. Yeah. Okay. Well, you'll have to tell me the issue. I'll look that up.
All right. Yeah.
And so the other 2 people, by the way, are Jean-Marie Denois and Kurt Selberg.
Yeah, me and Kurt talk about it, our art, quite a bit. We show each other our art and stuff. So yeah. And Jean-Marie, about 10, 15 years ago, he had never sculpted before, but he decided he was going to do a bronze. And he did a horse. It's kind of a tabletop thing with a horse rising up out of it. Cool.
And it's an incredible sculpture, really. And he had never done a bronze before, and he just found this foundry who would do it for him. And then, and I think then one of those went through the AEP auction. And I think Larry Bramlage bought it.
Yeah.
But it's an incredible bronze, and he gave it as a gift to my younger son. But yeah, I'm fascinated about that. I think that's cool. I think that's great that practitioners can, 1, have a creative outlet, and then 2, that they can take their knowledge of anatomy and the horse and use that in an art form. I think that's really incredible. I can't do that, save my life, but I think it's fascinating. You can.
Yeah. And so it's a great escape too, because when you're focused on that drawing or sculpture, that's all you're thinking about. And it's a good release for sure. Yeah.
Have you tried painting?
Yeah, I've done some painting as well. So I've done some watercolors. I've done some kind of mixed acrylic oil painting. It's a funny story. It's harder. So, it is much harder because you have color and all these things involved. And so I've got a funny story about that. I had back surgery 15 years ago, a laminectomy, discectomy. And I was on oxycodone, for the first week, and I'd never painted before. And so my wife, I said, hey, go get me some paints and a canvas. And so I stood on our back porch for a couple of days painting while I was, high on oxycodone from the surgery. And so I painted this really cool painting, and my wife calls it the high horse. And so we have it in our living room at the house.
The high horse. That's good.
Yeah. So I really haven't painted a whole lot since, but
well, let's talk about some veterinary topics here. And one of them, I know you had done some work. I've asked you some questions about this in the past, and I think it's good for the listeners to hear. But so let's talk about equine asthma for a moment. And so how are you differentiating equine asthma from other respiratory problems? And how then will morph into how you're treating it, and we can do it now or later as you want to.
Okay. Yeah. For me, a VAL is the best way, and I think the only true way to really know, because it also that way you get to characterize the type of asthma you're dealing with. As far as the inflammatory immune cells that are in the lungs, and so that can influence kind of how you want to do the treatment. So typically, the ones I'm dealing with are going to be mild to moderate asthma in our performance horses. Those horses that typically are pretty normal at rest, but when they start to work or exercise, they're coughing or having exercise intolerance or things like that. And so obviously endoscopy can be telling if you've got, we usually grade mucus on an endoscope. So I think that can be telling, because there is a strong correlation between the amount of mucus in the trachea and the presence of neutrophilic asthma. There's a good study that was performed on that. So I think that's an indication. However, like a mastocytosis, oftentimes those don't show mucus. So you're looking at BAL to know if you're dealing with mast cells or not. So for me, we do lots of BALs here, like lots of them. So I think that's key for me to be able to diagnose it and then characterize it so I can target a treatment.
Yeah. Now, can I tell you my BAL story?
Sure. Yeah.
I used to be famous walking in. I'd stick my head in, and they're in there doing a BAL, and I said, "Hey, when you guys are done waterboarding that horse, can you come out here and help me with the imaging?" And then, so it was a big joke in the practice, and then I did it one time while the client was in there, and I didn't realize the client was in there. So after that, I was banned from coming in the BAL procedure. But anyway.
Yeah. So, I mean, that's the gold standard for me, is the BAL. You can, some people don't want to spend the money on the BAL, and so you're going to have to just use your clinical judgment, endoscopy, symptoms, all those things, which we do as well. My treatment has evolved over the years, I think. Partially from some of my research I've done with using shockwave therapy, and also just the emergence of orthobiologics administered through a nebulizer. And so typically, we're treating horses with a combination of those things, as well as, obviously, number one for asthma is always going to be your environmental controls, decreasing dust in the environment. But I think most people know how to do that. That's kind of a easy thing to do, and the first thing you should do. But beyond that, I think nebulization is key to treating these horses, in combination oftentimes with shockwave therapy.
Yeah. Now, tell me a little bit about shockwave therapy, because I remember, looking at that work and discussing this with you years ago, and I of course remember, 25 years ago, when we first started using shockwave, one of the prohibitions was don't shock the lung.
Yes.
And obviously that's completely changed now. So why don't you tell me how we morphed into that?
Yeah. When I was at Arizona Equine, my back was bothering me back then. And so I wanted to shockwave my back to try to help it. But the rep there said, do not get this in your lungs, because it's going to, blow the lungs up, basically. And so I remember I was scared to death to shockwave my back, even though I did it, because I was afraid I was going to, rupture my alveoli in my lungs. And I shockwaved my back, and I was fine. And we shockwave backs all the time on horses. And when you're doing that, you're hitting the lungs. I mean, it's depending on how the depth of your trode. So to say all that, it seems safe. Like that, what I found out talking to some people is that it was specific. The reason I made that recommendation, it was specific to lithotripsy in children. And so using that very focused shockwave with lithotripsy, they had, I guess, caused some bleeding in lungs in children. And so that recommendation came from that. There was a study done at University of Cordova where they shockwave lungs on two horses that were going to be euthanized. And they did 3,000 shocks, focally without moving the trode at the highest energy setting. And the only thing they found on those was some mild hyperemia in the pleura. The lung tissue looked fine. So it appears to be safe. And certainly I've now done hundreds of shockwaves without any issues on lungs. So the safety part I'm pretty convinced of. I got into shockwaving them because I was approached by PulseVet, because a veterinarian, Marty Allen, who's on the standardbred racetrack in Florida, was shockwaving horses with the IPH, and saying he was having these great results. And so we work on a lot of barrel racing horses here in Texas, and they wanted me to see what I thought about it, try it, and see if I thought it was helping these horses. So we did a trial with it, shockwaving these barrel horses with the IPH. And I was doing pre and post BALs, and it was effective. But what I found was that it was, looking at those BALs, that the horses that improved, it was improving their asthma. And so I made that correlation. So then I followed that up with a study looking at mild to moderate asthmatic horses, mostly horses that were just showing symptoms during exercise, and kind of seeing how that would improve it. And so we ended up, I think, doing like 20, 22, 23 horses there. And I couldn't believe the results really with how those horses, from an improvement in coughing standpoint. And so that's kind of, now it's just become part of our practice, on those asthmatic, especially mild to moderate horses. It has not worked as well in the severe, the HEEVS horses. I have not had the same response on the severe ones. But we've seen a pretty significant response on the mild to moderate horses. And then secondarily, I think we're treating the bleeders by improving the asthma. Now, I'm not using it for the study. I just shockwaved it. That's all we did. But in practice, I'm combining it generally with nebulization. So, okay.
Well, say for a mild to moderate asthma horse, what is your shockwave protocol?
So you do 1,000 shocks per lung field on each side. We're doing the highest energy setting, E8, and I use the 80 millimeter trode, not because of the depth, because most of that energy is getting released at that air interface. It doesn't travel very well through air, so you're basically treating kind of the pleura area. But I just like the large aperture of that bigger trode because I can just cover more area. So we're doing 1,000 per side, so 2,000 total. Typically two treatments 2 weeks apart.
Okay. And how fast do you see response if you're going to see response?
Pretty quick. We see the most profound response after the second shockwave. Okay. So we in that one study, I think we had about 50% of the horses responded to the first one, and then it was like 90-something% after the second one.
Wow.
Yeah.
Okay. That's impressive.
Yeah. Yeah. We use the VAS, the visual analog scale score in the class, because that's really the most accurate way to look at response to treatment of asthma. We had an average of a 67% improvement on those scores on the horses that were treated. So we had 2 that didn't respond that had eosinophilic asthma. So it didn't help the horses that had high eosinophils, but it really helped the neutrophilic horses and the mast cell horses.
So eosinophilic asthma. Yeah. What do you do about that?
Steroids.
Okay.
Oh, yeah, and nebulization seems to help as well. But if they're not metabolic and they're safe to put on steroids, those horses respond really well to steroids. You can do inhaled steroids or systemic, but that seems to really help those horses. So.
And you and I had talked a few years back about using alpha-2 macroglobulin in respiratory disease as an inhaled product. And I was impressed after talking to you. I tried it back in the early days of using it. But I'm impressed. Now, obviously, you've done it a lot more than I have. Can you tell us a little bit about that?
Yeah, it's very effective. The nice thing about it is you get so many doses. And so you can do repeated doses. And typically the way we do it is we'll do every 3 days initially, kind of do a loading phase. So every 3 days for 2 weeks, and then I'll treat them for once a week. And it's a great treatment. I mean, it's a good maintenance too, because if they want to come back, and then once they're kind of get through that loading and they've finished out their single ones, they can come back and just pull more and just keep them on once a week on those horses that need a continual maintenance. And so we found that to be very effective. Now we also make our own, because we make our own PRP in the double spin phase of PRP.
Right.
So we pull off all that plasma, and then lots of horses that were injecting joints with PRP, then we pull off the plasma and send the plasma home for them to nebulize, and that's worked great too.
And so how much? I mean, was it 3 to 5 mil?
Yeah, we're doing 3 mils aliquots, and then we'll have them put about 5 mils of saline with it, and then run it through the nebulizer. It'll clog their cups up, so you have to run distilled water through it after every single time you administer it. It's going to ruin your cups, but
yeah, I noticed that.
Yeah.
Well, that's really interesting. And I had a horse actually that was in a barn fire, and he had never got burned or anything and got out okay, but he had kind of a lot of smoke inhalation. And I was impressed. I'd tried steroids. They didn't help all that much. And then tried A2M, and it really did help this horse. I mean, dramatically. And this horse had started bleeding and was really having trouble as you try to put him back to work. And the A2M was like magic with him.
Yeah, I've seen that a lot. Like we kind of are now become known for treating asthma in barrel horses. So we get a lot of those cases that just haven't responded to anything. And, that combined with shockwave, most of those horses were able to get them turned around. So
that's pretty incredible. I mean, that's something I think we ought to know more about, but I think it's fantastic. You've kind of led the charge on this and got it going. Now,
we were nebulizing amnion as well, even before A2M. And it's simple. Yeah. I was getting similar results. The problem is I think it's just the plasma type products are more effective because you can get 10 to 15 doses you can do as far as instead of amnion where you get 1 or 2 treatments out of it. So, yeah.
And I was going to ask you, are you freezing your plasma?
We are. Yeah. We're okay. Mm-hmm. Yeah. Having clients. Okay. We just send them home with a big bag that they freeze and dethaw, each time they want to administer it. So.
Okay.
Yeah.
You and I have talked a little bit, and I know you gave a presentation at AEP on the concept of the joint as an organ. And are we, do we have the right paradigm as we're approaching the joint? And I think certainly things are changing with that and have been for the last 10 or 15 years, and the speed of which it's changing astounds even me. And so I'd like you to talk a little bit about your viewpoint on that.
Yeah, I think it's really helpful to think of the joint as an organ. And the reason for that, I think, is it's basically comprised of a bunch of systems. If you think about it, it's got like a bone, it's got a bone system, the subchondral bone. You've got a nervous system, a vascular system, an immune system, a synovial system, cartilage system, capsular system, ligamentous system. So it's got all these different components that contribute to basically maintaining the homeostasis of that joint. And then each one of those systems is composed of cells. You've got the synoviocytes, the chondrocytes, the osteoblasts, and the way the joint really functions is communication between all those cells. So it's this complex system of cellular crosstalk between all these systems within the organ. And when that communication breaks down, we start to get osteoarthritis and all these conditions that we're treating in joints. And so most of our therapeutics now are targeting these cellular communications and trying to intervene and get these different parts of the system to talk to each other to reestablish homeostasis in the joint. That's a lot of what exosomes do, which is kind of the big, the new buzzword with orthobiologics, and a lot of research currently on exosomes is they're basically the communication packets between all these cells within this system that make this organ. And so I think it's just a concept that it's beneficial to think about it in that way when we think about treating it. Because even though you might be treating one component of the system, like say you've got a subchondral bone injury, those osteoblasts are talking to the chondrocytes, that then, over time you get cartilage damage. And secondarily to that, you end up with an inflamed synovium. So I think it's handy to think of the interplay between all these components and all these cells when we're thinking about how to treat it.
Well, and I think it's a really fascinating topic and one that is really relevant because I saw a horse we CT'd the other day, and that horse, it was a little off. It's an upper level horse, and you want to keep those horses, in the best shape you can do and do whatever you can do to, and this horse is not old, just kind of middle-aged, getting into its workload. And that horse had, I was surprised, it had 2 cracks in the bilateral crack in the central tarsal bone that had then healed by fibrocartilage. It didn't look new, a lot of sclerosis surrounding that. And, we were all kind of amazed how well the horse was doing and everything. And then, I was sitting there thinking, well, actually, this horse is going to continue to have problems. It's amazing it's doing as well as it is, but things that are amazing at how well they're doing, in my experience, tend not to last long. That's a magic moment. Savor it. It's going to change.
Yes.
And so, that's one that I was thinking about in exactly the way that you're talking about. Is I was thinking, gosh, what could we do to, one, reduce the inflammatory response in that joint, do whatever we can to stabilize the subchondral bone, and then, how can we support that joint and support the remaining cartilage? And so I was sitting there going, okay, well, let me think. I would go into the joint with an anti-inflammatory, try to calm it down, and then I would go back with something that is going to try to help the health of the synovium. And I think we didn't used to think about it that way. We just go, we're going to inject it. Okay. Bring it back. If it doesn't do good, or if it's still sound in 6 months, bring it back. We'll recheck it. And that shouldn't be our thought process. Our thought process should be more what you're talking about. So
I think it's a more long-term approach too, as opposed to just thinking about what's our short-term response to whatever we inject. What's the long-term goal here for this joint? So
and so as we're talking about that, let's also talk about orthobiologics. So if you're, and of course, orthobiologics now, you've got IRAP, you've got PRP, you've got different flavors of PRP, you've got A2M, you've got amnion, you've got a lot of different things. So which one, and I know it's going to depend upon the case, and feel free to illustrate, but which one do you reach for more commonly?
Yeah, I think it comes down to whether I'm treating like say a SDFT tear, or a suspensory injury versus a joint. But typically with my soft tissue injuries, I'm reaching for either an amnion product or PRP in most cases. That's just been my experience over the years. From a response standpoint, I think amnion I've probably seen the most consistent results with in treating soft tissue injuries. Like there's specific things like a check ligament. I think PRP is contraindicated in a check ligament tear.
I agree.
I blew one up pretty bad one time with PRP, and just talking to other people, I think other people have had that same experience. I have not had that issue using amnion on those. And
have you tried A2M on those?
I haven't. No. Have you?
I had one that was a phenomenal tear. I mean, this thing was just angry, and ultrasound was amazing. And we were actually, the horse had come up to inject its joints. And then they said, in that, we want you to evaluate that too. And so I'd already drawn A2M before I sedated it. And so I had this A2M, and I go, well, I'm going to go in there. I'm going to use some interlesional. I'm going to bathe this thing with it. And that horse, I said, bring it back to me. I want to look at it again, and I may inject it again. That horse came back to me in 3 to 4 weeks. And this is, as you see, you're too young for this, Beau, but I have the ability to do double blind work in my practice. If I don't look at the chart, I can't remember which leg it was. I'm old enough. And so I didn't look at the chart, and I just walked up to the horse, and we had clipped both legs. And I just stood there and looked at him for a minute, and I couldn't figure out which leg it was. and then I put my hands on it and I could figure it out. But I mean, that's how much the swelling reduced. I was really impressed at that. But you can get similar effect with with amnion.
Yeah, I've had really good results injecting those with amnion products. Yeah,
that's interesting.
Yeah, I mean, like I said, I won't go near it with PRP, but maybe I'll try A2M next time. But yeah.
Well, and I think the thing that is lost on a lot of practitioners, it certainly was early in my career, is that the problem with inferior check tears is that they are going to scar too much. And so it isn't that you want them to scar in more. You want to do anything you can to calm them down and slow that scarring process. You want them to heal, but you don't want them to scar excessively because they're going to do that on their own.
Yeah, that's a good point. Yeah. So, one other thing on the A2M that I learned from you was doing mesotherapy with A2M on these chronic suspensory branches.
Yeah,
I just brought that up because you taught me that or told me about it years ago, and I've had pretty good luck doing that. Which I think was an interesting approach to treating those. Yeah.
And again, it's just like that check. You're just bathing it in an anti-protease solution, and they're just gobbling up all those inflammatory products and proteases, and it just calms them down. So I think it's an amazing product. Now, so are you using more PRP or IRAP? Which
I don't use much IRAP.
I don't either.
Yeah, it's just I feel I don't get the length of response from it. I like something I can inject once, and not have to have them keep coming back on a weekly basis to re-inject. So for those reasons, I just don't use much of it. There are some cases, there's some stifles we used it in that, it seems to help maintain those horses. That's mostly where I'll use it, is in kind of a chronic stifle that we're trying to keep those horses in competition. But I don't use a lot of it.
Yeah. And that's another question I wanted to ask you is, so as we're using these various orthobiologics, and they're not corticosteroids, so they're not acting quickly. So how long do you take before you start bringing that horse back into work using orthobiologics as a rule? And feel free to differentiate if you want to.
Yeah, of course it depends. With A2M, I'll bring them back pretty quick. I mean, I give them to like 3 days, and I've seen that. I think it works pretty rapidly. I think IRAP can work pretty quickly. Generally with PRP or Prostrat on those things, I think it takes 2 weeks to really see those kick in good. Usually what I prefer to do is give them a week off, and then kind of a week, kind of bring them slowly back to work, and then 2 weeks kind of back to where they were if they have the time for that. Now we got plenty of horses that don't, and we still inject them with PRP, and they go back to work and seem to do okay, but that's generally kind of how I prefer to do it. Yeah.
And now even though we've been talking about orthobiologics, I want to talk a little bit about polyacrylamide gel, because at first I was sitting there and I go, well, polyacrylamide isn't an orthobiologic, and then I thought more about it and I go, well, hang on, it's affecting the synovium, and it's reworking the synovium, try to make it more effective, which is enhancing the health of the joint. Why couldn't you put it in a class of orthobiologics? And I realize that's a little bit of a reach, but tell me a little bit about your experience with it and your thought process.
Yeah, I have a similar opinion as you. I mean, we were first, I don't know, like 8 or 10 years ago, using the 4% when it first came out with some of the early clinical trials, and I saw a really pronounced response in some of these end-stage fetlocks and end-stage stifles with the 4% product. At the time, I couldn't get R from it. I started using the 2.5% about 5 years ago, or 6 years ago. And my thinking has evolved since then. Originally, I was thinking of it as more of the end-stage use, and now my thinking has evolved to all stages or pre-arthritis. especially with the CSU study that just came out showing the disease modifying benefits of it and how it integrates into the lining, and you don't get direct, the orthobiologic type response, but it's the secondary response to it, the cellular response you get in the synovium and secondarily in that joint that protects the cartilage and does all those things secondarily. So I agree with you. I think it's not a biologic, but it has a direct or indirect immune response in that joint that functions similar to our orthobiologics. And for me, I get probably the longest length of efficacy treating a joint with the 2.5% polyacrylamide of anything I use.
I agree.
A year to year and a half on some of these joints that we're getting 4 months out of with the other products. Even with, I've got plenty that we've done with PRP that we're getting 6 months out of, and we tried the 2.5%, and we get a year on some of these joints. So it's a great product. I use it a lot in tendon sheaths as well. I did a study a year and a half ago where we created lesions in the DDFT and in the manica in a horse in both front legs, and then went in and injected arthrimid in that tendon sheath afterwards. And basically, I had such good results with it, especially in manica flexoria tears over the years. That's my standard now. I'll put an orthobiologic in, a week or two after the injury, and then about a month in, I'll put arthrimid in, and just had really good results with those. I've quit doing surgery on most of them unless they're just completely ripped, and had really good luck. So I wasn't sure if the arthrimid was it integrating into the fibrillated part of the tendon, which I'm not sure would be a good thing, if it could impede the healing, or was it just affecting the synovium? So what we found, we did histopath on that horse, and the polyacrylamide was like spot welding the damaged synovium. It was attaching itself to the damaged synovium adjacent to the lesions we created, but it wasn't attaching to the healthy synovium. And so I thought that was pretty interesting. I mean, a lot of it probably ended up at the bottom of the sheath because of gravity, but the only part we could find around the proximal part of the sheath was only in the damaged part of the synovium adjacent to those lesions we had created. So I thought that was super interesting, and it kind of just maybe use it more in sheaths, really, because I think you're getting that same response in the tendon sheath that you're getting in a joint. So.
And now, sorry, what did you use to calm it down with?
So I usually come in with like PRP in those sheaths. Okay. Yeah, originally. I've used Strataflex as well. But yeah.
And have you used A2M?
I don't think I've used it. No, I haven't used it for those specific manica type cases, or border lesions and DDFTs. I'll use it like that too. So,
but I would assume you could use that and calm it down.
Oh yeah, I'm sure. Yeah.
Now,
sure.
have you tried corticosteroids in those?
Not anymore. I mean, I used to.
I kind of quit using that I used to do that, but I kind of quit, and I sometimes wonder if I still can't use it for the short-term calming down as long as I'm following it with something else. But I don't know whether that thinking's flawed or whether that's still a way you can do it.
Yeah, I think you get the secondary calming, like with the 2.5%. I think you start getting that effect about 2 weeks after you inject it.
Right.
Yeah. So it just depends on how quickly you want to get down. Sometimes we'll just use NSAIDs initially to get that effect if we don't want to put steroid in there. NSAIDs and ice or whatever, or cold therapy, and then give it 2 weeks, and then usually the 2.5% starting to kick in.
And then follow it with polyacrylamide. Now, in the study, we're using 2 syringes in the tendon sheath?
Yeah, we use 2 syringes. Yeah, we use two syringes. Okay. So 2 mils in the tendon sheath.
Yeah. Okay. Yeah. That's fascinating. I think, and I had always been, if it's a manica, send it to a surgeon. But I was fascinated by your study on that, gosh, you can get as good a results as surgery by just doing polyacrylamide gel. I think that's great.
Yeah. Yeah. I started using it earlier and earlier too. Like before I was waiting a few months because I wasn't sure when the right time to use it was. But once I did that study, I felt confident putting it in there pretty quickly. Like I said, usually about 30 days in, I'll put it in there now.
Yeah, that's, And that's, again, back to that thinking of the joint type thing that I was giving you that example of that case, is my thought now on that central tarsal bone with the fibrocartilage healing is to then go in there with PRP or A2M and just calm it all down, get the inflammatory aspect of it out of there, and then go back in there with polyacrylamide gel and see if I can stabilize that joint for the long term.
Yeah, that's what I would do. Yeah,
yeah, I think it is, like I say, I think our thought process on how we now we think about preparing a joint for a long-term solution, where before it was always just the quick fix and get it back in the arena. And I'm glad to see that's changing. And of course, always, as we say, do your diagnostics first and make sure you know what you're getting into.
Sure.
Instead of the process, and Tracy Turner and I talked about this, where the old, back when we were doing it, the old approach used to be, well, we'll inject them with the right side of the truck today, and then we'll come back in 2 weeks, and if they're not better, we'll inject them with the left side of the truck. And no diagnostics, and that was always the wrong way to do it. I don't know why that still persists in veterinary medicine.
Yeah. I don't know. Sometimes it's laziness, maybe, or just lack of knowledge to do the diagnostics that need to be done. I hate to say that, but because so much is available now. With ISELP and just the ability to ultrasound things that we used to didn't know we even had the ability to look at. That we've learned so much that we can image just with an ultrasound machine, the synovium, the cartilage, like all those things. Not to mention our more advanced diagnostics. I think it just gives us the ability to treat these things the way we should be treating them. So.
Well, and I think you're right. I think a little bit of it is, everybody's got a busy schedule and everybody's got too much to do and you're late to the next one and you really want to haul that X-ray and ultrasound out and look at everything and then the client goes, oh, well, it's going to cost more. And, it always reminds me of something my dad told me when I was helping him. He goes, Kent, there's never time to do it right, but there's always time to do it again.
Yep. That's a good saying. I like that. I'll have to use that.
Well, so what excites you about the future of sports medicine as you're going forward?
Yeah, I think one thing is the advancement of AI. I think it's going to enhance our ability to treat and diagnose. I use the Slipe app quite a bit. I don't know if you're using it.
Yeah.
So that's really enhanced my practice and my ability to follow up cases and diagnose cases that I probably couldn't diagnose or localize before. So I think just advancements like that are going to continue to help us. And just every day there's something new as far as orthobiologics and products that we can treat joints with. All this emergence of different types of exosomes and how they can target different cells within a joint or within a soft tissue. That I think just all this technology that's advancing, A, on the agentic kind of AI side, and then B, on the biologics and product side, I think is exciting.
Yeah, and I think, like I say, having just recently acquired a standing CT, we're amazed now at how easy it is to get some, it's a fan beam, so you can see the soft tissue. And that's amazing to me because, for years, if I had a complex hind limb lameness, I knew it was in the hock or PSL area, but, you don't see that much on the X-ray and ultrasound. Yeah, there's some stuff there, but nothing you can hang your hat on. And then you CT that thing and you can see the soft tissues well, you can see 2 millimeter tears that aren't that obvious on ultrasound, and you can see bony remodeling just clear as day, where it's very difficult sometimes see that on an X-ray. And so,
Yeah.
I just think that, exactly what you're talking about, all those things and the new diagnostics, we have the ability to get it right, where sometimes in the past we didn't have that ability. We just had to get along with what we had. But I kind of think that's not a very strong excuse anymore. If you want to get to the bottom of the case, you can.
Yeah, I agree. We have a CT as well, and it has made us such better, I think, diagnosticians, and especially looking at necks. Like we see lots of necks, and it has just opened our eyes to the different types of pathologies and things that we can address in necks that we didn't even know to look for once we started looking at these three-dimensional image of cervical vertebra and articular processes and all that. It's been eye-opening. So.
Yeah, I always thought I was pretty good at radiographing and ultrasound in the neck, and until I got the standing CT, and then I'm going, well, okay, I could have been wrong on that one. That's a little worse than I thought it was, and I didn't really appreciate that narrowing down near the foramina. You live and you learn. It's amazing.
Yeah, sometimes the CT is humbling. Like, you think you know something, you CT it, not what you thought, but it's good because you get the right answer.
Well, Beau, thanks for being with us. This has been a great discussion. I really enjoyed it, and I hope we can get you back on again sometime and cover some more ground.
Yeah, I'd love to. I enjoyed the conversation. I appreciate you inviting me to be on.
Okay. Well, thank you, and we'll conclude another episode of ISELP In Motion, and look for everybody down the road.